Good evening, everyone. Welcome to this week's webinar. We will start at 7:05, just to give people time to transition into the call. Good evening, ladies and gentlemen, and welcome to this week's webinar commemorating the World Suicide Prevention Day. Today, our speaker is none other than Dr. Nima Araka. Dr. Nima Araka is a double board certified psychiatrist and a leading voice in mental health. She's also the visionary founder of Fitahi Clinic, a top-tier psychiatry clinic committed to providing high-quality, confidential, person-centered mental health care. Dr. Araka helps individuals discover their path to living authentically by offering comprehensive and holistic mental health care that helps them tackle life challenges and/or mental illness while cultivating lasting experience. So welcome so much, Daktari. The floor is now yours to make your presentation. Daktari, you're on mute.
Thank you very much, Dr. Marie, for the introduction, and good evening, everyone. I want to acknowledge the effort that KMA is making to create more awareness around suicide and catching up with the current theme of suicide awareness, which runs between 2024 to 2026, changing the narrative. And in our effort to change that narrative, KMA came up with a theme where they say behind the smile, there's a silent cry. I'm trying to project screen one. sorry. And our conversation today would be looking at how we can change the narrative about suicide. Sorry, I think I'm having a bit of a challenge trying to project.
Dr. Ray, probably you could share with the presentation with me and I can help you project on my end.
Yes, I think that would be a good idea. Yes. How do I share it, please?
I've just posted my email on the chat.
Okay. Sent it. Sorry for the delay. So as she's going to project it, perhaps I could continue. I've sent it to you, Dr. Marie. You've received it.
Hi, Dr. Ray, I haven't received the presentation as yet.
Let me send it again. Okay. I'm very sorry for the delay. So as Dr. Marie is getting it, perhaps I could get started. So the conversation is about changing the narrative on suicide. And in our discussion today, I had a few things that I wanted us to discuss on, with the end goal of promoting healing as a viable outcome instead of reinforcing the outcome of suicide itself. I don't know if you've gotten it, Dr. Marie.
Yes, I have.
Okay, good. Thank you. And so when we're looking at suicide, and specifically today, we're trying to focus more on how suicide affects men. That will be the conversation. Now, what I plan is for us to be able to try and see how we can talk about suicide in a way that invites conversation, curiosity, and collaboration, to see how we can examine the different complex factors that drive suicide behavior, to allow everyone affected to feel included in the conversation about suicide. And this point is going to be really important because for most of the conversation, suicide is discussed around the context of mental illness. And we're seeing more and more literature showing us that it's a multifaceted phenomenon, meaning mental illness is one of the factors, but there are also other factors that people struggling with suicide might be affected by. And the third part is, how can we destigmatize the expression of suicidal desire without devaluing the rationale behind it? So when somebody wants to express perhaps their struggle with the thoughts of suicide, how do we listen to that person and give them the space to tell us how they came to those ideas, instead of, devaluing them by telling them, oh, there are all these reasons, that you can live for, there's all this that's worth living for, which then devalues the rationale that the person had developed to consider suicide in their life. And like I said, the goal is then to promote healing as a viable outcome. And so that's the second slide. And so to do that, please go to the next slide. So to do that, we can start by picking up from where Dr. Musheru left the other time. She had presented last week on the different aspects of suicide, and we can look at the current impact of suicide. And according to CDC, it shows that in 2022, about 12.8 million people had suicidal thoughts. And out of those, 3.7 planned to attempt, but only 1.5 attempted. And that's a big number. And then in 2023, suicide was the 8th leading cause of death between the ages of 10 and 14. And when you look at economic cost, in 2020, suicide cost more than 500 billion in terms of medical costs, value of statistical life. So here we're looking at how much a person is willing to pay to reduce the risk of mortality, and then quality of life, how much is a person willing to pay to increase their quality of life. So if somebody is struggling with life challenges and those life challenges are reducing their quality of life, how much are they willing to pay, maybe in terms of therapy, in terms of coaching or other methods of intervention to increase their quality of life? And it was shown that in 2023, for every suicide that happened, there were at least 10 emergency department self-harm presentations. There were 48 people who reported to have attempted in the last year, and 325 intentions. And other studies show that for every suicide, about 40% of those affected might have a prior history of suicidal attempts or history of mental illness, meaning there's a 60% in that number where those people do not have any antecedent mental illness. They don't have any history or do not fit a diagnosis of a mental illness, which then brings us to the conversation today. Next slide. Where we're looking at suicide, not necessarily only in the context of mental illness, but also outside it. And today specifically, we're looking at it outside the context of mental illness. And you can see this is part of the DSM. When you look at other conditions that may be a focus of clinical attention, you can see the different problems that psychiatrists is expected to acknowledge because they accompany some of the mental illnesses that a person presents with, but they're not mental illness. So you can see suicidal behavior, you can see non-suicidal injury, abuse, and neglect. So these are normal life problems that may accompany mental illnesses. Now, for suicide, like I said, when we look at it in the context, for example, suicide is a symptom of depression. Suicidal ideation is a symptom of depression. Suicidal ideation can be a symptom of mania, bipolar during a manic episode. And so out of that context, what is suicide? Next slide. And so you can look at this study where it shows that 1 in 4 people who attempt suicide does not have a past history of psychiatric disorder or does not meet the diagnostic criteria of a psychiatric disorder, meaning 3 out of the 4 do meet. And so you can see a larger proportion of people who attempt suicide or have suicidal behavior do have a mental illness or pre-existing mental illness or prior suicidal attempt, but there's also a percentage of people who do not qualify for diagnosis of mental illness or do not have previous mental illness, but still attempt suicide. Right? Next one. Now, here we want to look at the story of Peter. He's 33 years old. And you can see his chief complaint is, I can't do this anymore. I'm tired. That's what he's complaining about. And when you look at his history of presenting problem, we still follow the same method of history taking. Peter has been fairly well until 3 months ago when he started finding it increasingly difficult to go home at the end of the day. He reports feeling overwhelmed and hopeless. At home, his wife constantly complains that he cannot do anything right and compares him to other men who can, which makes him feel very small and worthless. Peter has tried severally to tell his wife that those things hurt him, but his wife accused him of using his emotions to manipulate her into feeling sympathy for him. Due to his prolonged physical and emotional unavailability to his family, his wife has labeled him a narcissist because Peter is nice to everyone else out there except to his wife. And this narcissistic label has made Peter feel a bit too self-conscious around his family, friends, and colleagues, to the point that Peter now dreads all social interaction. So he's becoming extremely shy or maybe even having some tendency or symptoms of social anxiety. And this has made Peter isolate himself a lot more than usual. So he's been feeling a bit lonely, lost most of the time. And lately, every time Peter goes to bed, he wishes he didn't wake up the following day. But he says he doesn't want to end his life, but he just can't see himself living this life anymore. Now, Peter is a medical doctor. Let's say he's been a medical officer for 3 years. He's married with 3 children, lives in Kileleshwa here in Nairobi, and his wife is a nurse. Now, when you look at Peter's story, just from a quick glance, I'd like to get some interaction from the participants. Do you think Peter has a mental illness? So you can write MI if you think that. Do you think Peter has a mental health challenge? So you write MHC, you can just type it. Or do you think Peter has other things? So you can write O. So maybe you can share your responses. MHC for mental health challenges, MI for mental illness, and O for otherwise. Just give your answers based on just a quick feel. Okay, thank you for the responses. Mental health challenge seems to be the answer that keeps coming up most. MHC, MHC, okay. Okay, MI. All right. So let's look at the next slide and then we'll come back to this one. So I want us to go back to basics a bit. Suicide is definitely a mental health challenge, definitely. Most of the time, as we've seen, it is related to mental illness, but all the time, it is a mental health challenge. And I'll explain why I'm saying it's a mental health challenge. So when you go back to basics, you can see the definition of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We all know this definition. And because the discussion is around mental health, so we focus on the mental part. Now, when we're defining mental health, in very basic terms, mental health is how you think, how you feel, and how you behave, and how these three different components allow you to function on a day-to-day basis, allow you to cope with life challenges, allow you to contribute positively to society. And so your thoughts affect the way you feel, the way you feel affects the way you think affects the way you behave, the way you behave affects the way you think and the way you feel. And so if there's a problem in the way you think, then you expect that there might be a translation of that in the way you function. So for example, if you're unable to think clearly, then you might not be able to be productive that day. If you're not able to think fast, then you might not be efficient that day. And that is a component of mental health. And daily function here ranges from, small tasks to big tasks, simple to complex. And so, for example, you having seen the poster for this CMA and registering it in your mind that you want to be able to attend the CMA, that's a function of your thinking, your ability to connect this event and absorbing it into memory so that today you can be able to retrieve it and remember to be here on time and to even make that time and to know where you're supposed to be at this time. All that is function. And you use your brain to think to enable you to function. And so waking up in the morning, sleeping at night, all these are functions, brushing your teeth, talking to people, being able to plan your day, organize your day. All these are functions that you do on a day-to-day. And then coping with life challenges. And now this is where now we come to the conversation of Peter. So coping with life challenges. If we go back to the previous slide, we can see maybe some of the life challenges that Peter has been struggling with. So for example, you can see he's been finding it increasingly difficult to go home. You want to be able to go home at the end of a working day to rest, to unwind, to spend time with your family, to be cared for or to care for someone else. And Peter is not able to do that. So there's a bit of impairment of function there or a difficulty in performing that function. And you can see his feelings are also overwhelmed. So there's a problem in the way that he's experiencing his emotions. He's hopeless, and hopeless can be both a thought and a feeling. And so you can see how these aspects of mental health are coming out in Peter's story. His wife is constantly complaining, and because of the complaining and comparing him to someone else, he feels very small and worthless in that relationship. And you can see he's tried to help himself out of that situation by trying to tell the wife that these things that you're telling me are hurting me. And so this is his effort to try and cope with the challenges. But it wasn't very fruitful, because then he was accused of manipulating, which even made him feel worse. And so now he's interacting with people, wondering if he is a narcissist, looking at how he interacts with his family, how he interacts with his friends, and trying to see what his wife is saying about him, that he's very outgoing, very nice, very friendly, very jovial with people out there, but not doing the same in the house. And you can see how these things are affecting him, such that now he's not as outgoing as he used to be since the wife started labeling him as a narcissist. And so there's a bit of social isolation as a result of that. And when it's inevitable that he has to interact with people, you find that he is experiencing a lot of shyness that was not there before. So he's self-conscious. Self-conscious is an increased acute awareness of yourself. So Peter is worried that other people might see just how maybe small he is, how worthless he is, how much of a narcissist he is, because the wife is labeling him that way. And you can see these struggles. If we can go back to the next slide. So Peter's mental health is getting challenged. The next slide. Yeah. he's trying to cope with this one. He's trying to cope with the challenge. Some of them maybe he's able to, others is not. So coping with the challenge can look like, because I'm feeling self-conscious or too self-conscious, then one of the ways to cope is to reduce social interactions. And in the immediate moment, that can feel very helpful. But if you continue doing it for a long time, then it becomes very detrimental, because social isolation is one of the factors that contribute to loneliness, which then contribute to mental illness. And so the other part is contributing positively to society. And here we can see Peter is a medical doctor, so he's able to go to work, and he's been taking on a lot more shifts, so he stays a lot longer at work, which means that he's contributing more positively to society. But then you want to ask yourself again, at what cost? And the reason he's staying more at work is because going home, just the thought of having to go home is tiring. So the activity of going home is even more tiring. And so he opts to just stay a bit longer in the hospital. And you can see, according to CDC, when your thoughts align with your feelings and your feelings align with your behavior and your behavior aligns with your thoughts, then you're able to function well, more productively, you're able to cope with life challenges, you're able to contribute to society. And that is really crucial for overall health and quality of life. And so all these things, the three aspects of mental health, you do them every single day. And I've come to learn from the different conversations that I see going on that people tend to equate mental health to mental illness. Mental health is this: you thinking, you feeling, you behaving, you talking, you listening, you right now thinking about what I'm saying and whether it's making sense or not. That is mental health. Your ability to process what I'm saying right now, your ability to read what I'm saying and then to process it, that is a component of mental health. So each one of us at any given point, day or night, has this function going on of mental health because it's part of health. And so when we look at suicide and we say everyone, it can be at risk, everyone can be affected, we mean every human being that has the ability to think, that has the ability to feel and behave, can be affected by suicide or can be affected by ill mental health or mental illness. Because all of us rely on mental health as a crucial component, as an essential component of general overall health. And so now, before we go to the next slide, I think I'd also like to engage with the audience again. Do you think at this point, if you were to rate yourself, that your mental health status is good? If it's good, say 1. If you're not sure, write 2. And if you know it's not good, write 3. So 1, you've got very good mental health. 2, you're not sure it's good. And 3, you know it's not good. I just get a feel. 2, 3, 3, 2, 3. I hope Kema is taking note of that to see how we can maybe shape this conversation in a more targeted way. 2, 3. There are very few ones. Okay. Lots of 2s. Okay. So then this question, I won't be asking for an answer, but I'll just be asking you to reflect. How do you know, what indicator do you look for to know that your mental health is not good, right? And generally, we go back to the 3 components. You're looking at your thoughts, you're looking at your emotions, the way you feel your emotions. And for emotions, it's very important to understand that when you see people saying that emotions are objective, it's only in the sense that, for example, in this particular interaction, I am talking to a number of people, and most of you are more knowledgeable than me. So it's conceivable in this situation for me to feel a bit anxious and maybe to even show the anxiety. And so fear in this situation is objective. It's an objective emotion that somebody can feel. But then feelings is the way that a person experiences that emotion of fear. And so one person might be able to, hide their fear very well. And so when they talk, you feel like they're very confident. You see that they're very confident and you can't even see the fear. And another person feels the fear and it's very obvious. You can just see it in the tone of their voice, in the way that they move their hands and they're shaking or trembling. And so feelings is our subjective experience of an emotion, whereas emotions is the objective. Like if I tell you that we're having a meeting at 7 and then I don't show up at 7, the objective emotion there is disappointment. Now, the way that I'm going to experience that disappointment, whether I'm going to experience it at an intensity of 10 out of 10, whether I'm going to experience it for a week and another person might experience it for a day, the emotion is disappointment, but the way that we feel that emotion is what varies from one person to another. And so I'm hoping that one is helpful in when you're reflecting how to, assess as an indicator whether your mental health is good. So you might find that before when you were very productive, very active, and very healthy, the way that you felt emotions was quite proportionate. You would feel disappointed, but it would not affect your whole day. You'll just be able to contextualize it in the situation that it happened. But now you find yourself unable to regulate that emotion, such that when you go to the next context, in the next interaction, you take it there, and that would be an indicator that something might not be going well with part of your mental health, and that would be the emotions. Same with behaviors, the way you react. Same with thoughts. Before, when somebody would criticize you about something, you'd be able to try and look at the criticism from the other person's point of view and also compare it with your own point of view. And that process would be very smooth and seamless. Yeah. And in a day or two, you'd be able to overcome that criticism and you're ready to take on other life experiences. But now you find yourself stuck in this repetitive pattern of negative thoughts about what the other person is saying, because now you feel like it's confirmed or it's proved something that you thought about yourself, which is maybe you're not worthless, maybe you're worthless, or maybe you're a failure, which are thoughts that you already have. And now you're stuck in that pattern of the same thought. And that would indicate to you that something might be wrong with an aspect of your mental health. And so on the next slide, so when we look at Peter, this is just for perspective. Good mental health means you don't have any symptoms. It doesn't mean that you're not struggling. It doesn't mean that you're not sad, you're not disappointed, you're not frustrated. You are, but you don't have any symptoms. Like you're able to deal with whatever life is giving you. So no symptoms at all. And then we've got the middle part where now you're facing a life challenge. Maybe there's a divorce that's coming, or a separation, or you've lost a loved one, and you find yourself struggling now, right? You're struggling to think clearly through that situation, but then you're overwhelmed by emotions. So it's very difficult for you to think. It's very difficult for you to feel the emotions because you don't know what to call them. You don't know what you're supposed to do with them. And so you find a way to escape those emotions. And one of the easiest and fastest way to do that is typically drugs, maladaptive behaviors, or behavioral addictions. And so in the life challenge, you find that you might be having what I just mentioned in the aspects of mental health, right? Your thoughts are a bit irrational, inaccurate. And because of that, in the life challenge, you're still able to function. You're still able to function, but you're struggling to think, you're struggling to make sense of things. And the challenges you're facing or the struggles that you're in do not meet a diagnostic criteria, right? And this is a life challenge. And then when it comes to mental illness, you've got symptoms where your irrational thoughts are now impairing your ability to function. And so if, let's say, your irrational thought is that you're not good enough, right? Then the way that they're going to impair your ability to function is you might find yourself isolating socially to the degree that now even the thought of isolating makes you anxious, and anxiety now manifests as physical symptoms or psychological symptoms. And so you can see between life challenges and mental illness, there's a common feature there that then makes it really difficult to separate a life challenge from a mental illness. And this is really important to understand, because it's very easy to diagnose somebody with a life challenge with a mental illness, and it's very easy to diagnose somebody with a mental illness with a life challenge. And it's critical then to learn to distinguish, to learn to see the nuances in these two things, right? In these two sections. And one of the common things that make it even more difficult to distinguish is the cognitive distortions. And this is the way that we perceive reality. And you'll find that in the life challenge, you have the cognitive distortions, and in the mental illness, you have the cognitive distortions. In fact, in depression and anxiety, I've seen studies that show up to 80% of patients with depression have cognitive distortions. They have a distortion in the way that they perceive reality. And so they don't perceive reality accurately, they don't perceive reality rationally, they don't perceive it realistically or logically. And that's a dysfunction in both life challenges and mental illness. And you can see now, if a person has this, it's very difficult to know, is this just a life challenge or is it a mental illness? And so with Peter now, there are people who said that he has mental illness, but I saw most people saying that he has mental health challenge. So mental health challenge is similar to life challenge. And the reason why it's similar to life challenge is because your thought is affected, your emotions are affected, and your behavior is affected. And most of life is just that. We think, we feel, we behave. All of the innovations that we've created, all of the things that we've made are a result of our thoughts. Creativity is because of thinking. Innovation is because of thinking and feeling. And so inspiration comes from emotions and thoughts. And so all of our life is just how we think, how we feel, how we behave. And so for Peter now, these things are getting a bit impaired, are getting compromised, but they haven't yet caused significant impairment in function. Yeah. And now when we got to look at cognitive distortions, let's look at the next slide. Sorry, so before we go to the next slide, sorry. For the people who had said that their mental health is good, and now that I've described that, please go to the previous slide before this one. And now that we're looking at life challenges, and life challenges, they're normal things that happen. Would I get different answers? Can I try again? How would you rate your mental health status right now? 1, for no symptoms at all, you've got good mental health. And that means, yes, you're getting disappointed, you're experiencing the full range of life, but it's not overwhelming you. You're not having anything compromised. And let me see, 2 would be life challenges. You're struggling, but you don't have a mental illness. And 3, you feel like you have a mental illness. So here, impairment of function is you're feeling so fatigued, you can't get out of bed. You're pushing yourself more than you should, and you can feel it. You can feel the exhaustion just setting in because of pushing yourself. You can feel that your appetite is affected. Lots of 2s again. 1. I like the 1s, yeah. You're struggling, but you're coping well. Okay, lots of 2s now. So the arrow points from life challenges to mental illness. So a lot of people might be on number 2, where they're facing life challenges and they're really struggling. And if they are not careful with their coping mechanisms, with the resources that they need to enable them to cope with the challenge, then they can easily go to the mental illness. But also, if they cope well, they can also easily go back to good mental health. So all this is the life challenge and then the ability to cope. So the internal mechanisms or the external support that a person needs to be able to rise up to the challenge and face it. Yeah, so that can easily bring you to good mental health. But if you're not aware and you start using maladaptive coping mechanisms in the life challenges, and maladaptive, like I said, most of it is addiction or substance use disorder or behavioral addiction, where you want instant gratification, instant escape from your problems. Then in the moment, yes, you feel the relief. You feel like you've forgotten that your wife called you a narcissist. You've forgotten, Peter has forgotten, if Peter is using the alcohol in this case, he's able to quickly escape his problems, but then that then predisposes him or increases his risk to going to the next one, which is the mental illness. And so you want to be really careful when you're facing a challenge to ensure that you're really replenishing your resources to face that challenge, your coping mechanisms to cope with that challenge. And one of the easiest coping mechanisms is getting restful sleep. The ability to sleep at least 8 hours a night or 8 hours a day, uninterrupted, and waking up restfully. That is one of the most important resources. Of course, there are others. Now, when we go to look at the cognitive distortions, let's go to the next slide. And so here's my question. Do you think Peter is perceiving reality as it is, or do you think he's distorting it to fit his perception? One, he's perceiving it as it is, and two, he's distorting it to fit his perception. What do you think? How many think Peter is perceiving reality as it is? One. And how many think lots of, okay, one, two. So you can see that shape, lots of two. So Peter is perceiving reality, has distorted reality to fit his perception. Interesting, quite competitive. Ones and twos. Okay. So let's say the shape we see there of reality, Peter has distorted it such that everything seems the same. You can see it's the same shape all over, meaning he's distorted what reality is and has made it what he wants it to be. That's one way to look at it. But the other way to also look at it is maybe the perception and his perception of reality is reality. So those are two possibilities. And as we keep discussing, we can see how that goes. So the next slide. So here it is. And my question first, before I explain these two pictures, is how many here, and just say yes, how many here perceive reality as it is, the objective, let's say 90% of the time? How many believe that they're objective, they're logical, they're unbiased, 90% of the time? Just yes. Anyone? There's got to be one person or two who are, right? Yes, You're objective. Yes, yes, no, yes, Good. My answer is no. Okay. No, yes, mostly. No, no. Okay. Okay. So then I'd be wondering, the ones who are saying yes, how much self-awareness do they have? And the ones who are saying no, how much self-awareness do they have, right? And maybe when I explain the picture, so you can see the first picture in blue where you've got somebody lying in the couch and the other one, a frustrated student maybe. So let's say the frustrated female student is a fourth-year medical student. And the lecturer has given them assignments, right? And here you've got the internal medicine lecturer, you've got the surgeon, you've got the obstetrician, the OBGYN, the pediatrics. Everyone is giving them assignments, including psychiatry. And every lecturer expects that their work is done. And so when the work is not done, the perception of the lecturer is that they don't try hard enough. They have plenty of time. Why are they not finishing their assignments? But the reality of the student is that there's just not enough time to get it all done. I mean, if 5 days a week we have, and it's not one lecturer, it's maybe two lecturers. So you've got two internal medicine lecturers giving you an assignment, you've got two in OBGYN, you've got two in pediatrics, and so you've got double assignments. And there's no coordination to see how much assignment you can give the student. And so when you give it, you expect that they have time to do. But then if there's peds twice, and then there's psychiatry twice, and then there's internal medicine twice, you can see there's not enough time. And so from the lecturer, they and this would this would be what we call jumping to conclusions as a type of a cognitive distortion, where you're not getting the full picture, but you're already making an assumption. You're already making a conclusion that this student is just lazy. And really the student is getting overworked. And so you can see the lecturer's perception, which is limited, which is not actually looking at the entire reality, but looking at the way that they look at the student. And then the second one now, you can see this rhino has got a long horn. he was born with it. So he's grown up seeing it in front of him. And every time he looks out at the world, he sees that horn. And for him, the horn belongs to the external world, not a part of him. And you can see every drawing he makes, the horn is there because it's part of the external reality. Yet it really is just how he sees it, not the way it is. And the thing that makes this very important in our discussion is when we look at the theory that we're going to tackle in the next slide is the interpersonal psychological theory of suicide, where the psychological part is what we're dealing with now. The way that the person sees reality has been distorted, has been compromised, such that they're not seeing reality as it is, they're seeing it as they are. And as they are here, when it's good mental health, it means you have a view of reality more accurately, more rationally, more clearly, more logically. And so even if you see the world as you are, the way you are is, well thought out or well thought through. You're able to actually assess your thoughts and see if they're rational or irrational. You're able to make that assessment. That's good mental health. But when you come into the middle, when you're having the challenge, you don't realize that you're actually in the middle. You don't realize that your thoughts are distorted. And so you tend to then impose the way that you see reality as irrationally as you see it onto other people. You make them see it as the way you've seen it. And in this picture of the rhino, I think one of the most common discussions going on social media now or in public discourse is our childhood wounds, right? The adverse childhood experiences that we suffered from. And because we grew up in an environment that was abusive, that was not conducive for good mental health, then we grew up having that horn the way that the rhino has it. And so as we grew up with these wounds and trauma, then we grow up with them. And so we keep seeing them as we go along. And we find ourselves interacting with the world through that pain, through those traumatic experiences that we went through in childhood. And so you can see the way that we see the world is rarely, in fact, this is not a study. I saw this article that says at most maybe 2% of people in the world see reality as it is. Most of us, 98%. And like I said, these are not based on scientific findings, but it's just an article I saw. See reality as we are. So the way that we've had our past experiences, the biases that we have, the stereotypes, the attitudes that we formed, towards different things. And so most of us relate very closely to the rhino. Yeah. And that's why I said, maybe when we're making an assessment of how aware we are about ourselves, the way that we think we see reality and the way that we actually see it, that discrepancy there, the ability to know it, that's very good self-awareness. So if you know the distance between how you see it versus how you think you see it, being able to see that, that's good self-awareness. But if you don't see the distance, yet there is one, then you probably need to re-examine your self-awareness and re-examine the answer that you gave today. Now we move on to the next slide. So still on cognitive distortions, right? And these are some other examples. I gave one, jumping to conclusions. You can see in the image. You see something, you don't have enough details, and we do this a lot. And you want to be very aware when you're doing it so that you can know where you are, right? Do you have good mental health where you're not ready to maybe comment on something or make assumptions about something unless you have, full information or more information? Other cognitive distortions include emotional reasoning, and this one is usually one of the worst to have because you think that the way you feel as strongly as you feel it, then it has to be factual. So if Peter's wife, because she feels that, Peter is not nice to her, but nice to other people, because she feels that Peter is a narcissist, then Peter is definitely a narcissist. And so you can see this emotional reasoning, which then can really contribute to a feeling of disconnectedness. Because if Peter might be making an effort to connect with the wife. Might be, let's say, making plans to have dinner, but the wife is tired or is not available, or Peter tries to come home with gifts to give the wife, but the wife thinks Peter is being disingenuous. And so the wife is focused on this narrative that she's built in her mind, that Peter is a narcissist. Peter cannot do anything right. Peter doesn't love me, right? And so her eyes are focused, so her attention is on that. It's very hard for her then to see how Peter is expressing his love for her as evidence that Peter actually isn't a narcissist. And that's why emotional reasoning is one of the worst. It's because once you form that narrative in your mind, once you have that belief in your mind that something is, because you feel it so strongly, then you can't, no one can challenge it. And so we have so many of these, and sometimes we do it in a small degree, in a medium or a high degree, and it really does cause conflict in the relationship. It brings, in fact, emotional reasoning often contributes to getting a relationship to a part where you've reached an impasse. There's no way to solve the problem because one person believes that they're right, and there's nothing that can be said. There's no evidence that can be how right they are because they feel they're right. So emotional reasoning is really, really difficult to deal with in a relationship. I feel bad, therefore it is bad, yeah? If I'm feeling anxious in this particular interaction, then this has to be a threatening situation just because I feel it. And so emotional reasoning, and you really want to evaluate yourself and see, have you been in situations where emotional reasoning has directed your decisions, and a decision here would be that it made you end a relationship because you felt so strongly that this person wronged you and you didn't look for facts because the way you felt is the fact. And so you ended that relationship just because of emotional reasoning. And a lot of us do, knowingly or unknowingly, yeah. Others include labeling, when you say, I'm a failure, I'm guilty. Instead of looking at the situation and seeing what happened, you just label yourself. And you usually use negative labels here to make sense of the situation. And so Peter here is feeling is lost. Peter is worthless. So these labels may indicate cognitive distortion, mental filtering. Yeah, we're having this interaction here. Everyone is having a different experience, one from the other. And there's somebody who's looking at how many times maybe I've made grammatical errors, or how many times I've stuck on the slide, how long I've stuck on it. And so they're looking to filter out anything positive and to just look at how negative it is. And this can be happening very unconsciously. So you're not even aware that that's what your brain is looking for because you gave this instruction so many times. It's almost become a habit now that when you're engaging in a situation or an interaction, you look for the negative, you filter out the positive and you focus on the negative. And so out of this slide, you'd be like, oh, it was so boring, or she did this or that, or people were asking questions, or people were. And that is mental filtering, and you want to be aware of it to see if it is a symptom of a cognitive distortion. And like I said, cognitive distortion can be in mental health challenges or life challenges, and can also be in mental illness. And all or nothing, and I encourage you to go and look at the other types of cognitive distortion. All or nothing is also very hard to deal with. Yeah, still using the example of Peter. Maybe Peter has done 7 nice things consecutively, right? But the 8th thing he did, he didn't come home as early, or, he just didn't get it right. 7 he did, 1 he didn't. And if the wife has, as an example, this cognitive distortion of all or nothing thinking, then Peter has not done anything. The last 7 times he's done, he hasn't done it right because of this one time. So Peter has to either do it right, 10 out of 10. If he does it 9 out of 10, he's not right. It becomes nothing. He has to do it 10 out of 10 to be all. So this all or nothing, we also call it black and white thinking. It can be very difficult to deal with. And I think some of us may have experienced it in our upbringing. We may have had parents who are like this. So you do 4 things right, you do the 5th one wrong, and you're the worst child they've ever had. And they cuss you and they, pelter you all these abusive words. And so I encourage you to look at the different types of cognitive distortions and perhaps try to self-assess to see maybe which ones you might be struggling with that might be making it difficult for you to deal with. You see, with the distortion now, you don't see the challenge as it is. You see the challenge as inaccurately as your distortion is. And so, which then can often lead a person to these feelings of being overwhelmed, not being able to sleep at night because they can't get unstuck from their thought process, which they need to be able to tackle the problem. And so you want to be aware of this. Next slide. Oh, sorry, I keep, sorry, Dr. Marie. Maybe before we go ahead, just to get a feel of how we understand the distortions, how many were able to see some of the ones that they may have had, not now, or they've seen it in others? So the answer would be yes, to mean that you've seen it in yourself in the past, not necessarily now, or you've seen it in other people. Cognitive distortions. And maybe you could write the one that you've seen from the ones I've described. Could you take the slide back? Please write the one that you've seen. Write all or none. Yes, I like that. Write the one that you've seen. Instead of the yes, write reasoning, emotional reasoning, mind reading, jumping to conclusions. Which one have you seen? Mental filtering, all or nothing, jumping to conclusions. Jumping to conclusions, labeling. All or nothing, emotional reasoning, almost, labeling, mental filtering, emotional reasoning, jumping to conclusions, mental filtering, black and white, all or nothing, jumping to conclusions, all or nothing. You can see those responses. Intellectualization, emotional reasoning, jumping to conclusions, black and white. Black and white seems to come up a lot. All or nothing is black and white. Emotional reasoning. Yes, you can see now what brings conflict to a relationship, right? Sometimes it's just a distortion in the way that a person perceives reality, not that there's actually a problem in the relationship. And this becomes really important to distinguish, because the way that you're going to go about solving them is different. If there's an actual problem, a real problem in a relationship, you're going to tackle it differently from if there's a distortion in a person that is bringing the problem in the relationship. Mental filtering, good. Okay, thank you. We can go to the next slide. Now we can look at the interpersonal theory of suicide. So there are many theories around suicide, right? The common one, like I said, is suicide as a result of a mental illness. But here we're looking at interpersonal theory of suicide. And like I said, the way that this theory is labeled, it can be interpersonal psychological theory or interpersonal theory of suicide, but it's the same. And initially, this theory was done by Jonah. I keep getting his name wrong, but yes, in 2005. And then it was improved by another researcher in 2010. And then now they've done a systematic review and meta-analysis of decades of the cross-sectional, cross-national research. And you can see there are two main factors in interpersonal therapy. One is the thwarted belongingness, where a person feels disconnected, isolated, alone, lonely. And then you've got the second one, which is perceived burdensomeness. And here it's usually associated with a lot of self-loathing, a lot of self-hate that tends to translate to you're expendable. And so that means when you're not here, people might not feel as much a loss. And so you ending your life would be relief to the people around you. And this mostly comes from, here he says perceived, right? And it's possible that it is perceived, it's not real, meaning this person is not a burden to their family members, but because they think, like I said, because they've strongly attached themselves to this idea that they're a burden, then they're not able to see the evidence of the care and the affection that's genuine that they're actually getting from their family. And so in this case, it's a perception, not a reality. But it can also be real, and I think I've included a critique for this particular theory or this research, where you live in an environment where you're not wanted, and people show you that they don't want you. And so in that case, it's not perceived, it's actually real, that nobody wants you. And so that will now would impact the person differently because now the perception and the reality are aligned. Yeah. And then these two, then when they go on for a long time and the person is not able to get out of this loop of thinking, this repetition of thinking, it's intractable, then they become hopeless. Yeah. And then this hopeless now is what is going to yield into desire in suicide. Because now I'm always going to be a burden. And every time I look at my family members, I feel like I'm hurting them. My presence is hurting them. And maybe you're in a melancholic mood, or, you've got this cloud over you. And so you feel like it's going to infect them. And the more you isolate, the more hopeless you get. And this suicidal desire is what then might lead a person to develop what we call a capability for suicide. And when a person has the capability for suicide, then they're likely to attempt. And they can attempt either with lethal means or non-lethal means. Yeah. And so according to this theory, our interpersonal relationships, and we've started from there, right? We started by looking at what is the definition of mental health. And then we saw Peter's story and we saw how his relationship is challenging him and how these challenges are beginning now to affect other areas of his life besides his marriage. And so he started feeling he may have felt maybe a sense of thwarted belongingness where he feels alone in the marriage. And then the more the wife complained, everything he did is wrong. So he looks at his wife complaining that everything he does or doesn't do is wrong. So that might start making him feel like he's hurting his wife. He probably has a conscience and he doesn't want to hurt somebody or to see somebody hurt. And so this now starts bringing in the burdensomeness. Yeah. And in this case, it might not be so perceived, because if somebody is constantly telling you that you are hurting them, you are the cause of their problems, you are the cause of their unhappiness, as a human being, you're going to feel bad about being that cause. And so the burdenness can come in. And if it continues, it persists, mainly because you find that Peter is putting himself in situations where it perpetuates the thwarted belongingness and the perceived burdensomeness. And so the hopelessness now sets in. When the hopelessness sets in, you see life as being that way. He's 33, maybe he's got another 50 years to go. So 50 years living like this. And maybe that's why he's saying he's tired. And so maybe he's not aware. He says that he doesn't want to kill himself, but he wishes he didn't wake up. And so there is a passive desire there to kill himself, yeah? And so that passive desire could easily lead to capability for suicide. Now, this is the initial theory. And then the bottom one is the meta-analysis that was examining these theories, yeah? And so that's why it's very similar. Now, let's look at the next slide. So here, we're still looking at Peter. And we're looking at some of the things that he's struggling with in terms of thwarted belongingness. Now, belongingness is not just one feeling. It's a collection of small, small feelings, if we can look at it that way. And belongingness is being part of something, part of a group, part of a family, part of... And you can see for Peter, maybe the reason why he's working more at work, he's spending more time at work, might be because he lacks the sense of belongingness at home with his wife and his family. And so at work, he gets to maybe achieve that. He gets somebody who asks him how he is and actually listens to him. And so you might find that Peter has found a way to get a sense of belongingness at work. And you might find the other thing that is well reported is that the reason why extramarital affairs happen in the workplace is usually because at home that sense of belongingness is missing, is deprived. And at work, you spend a lot of hours there and people are very cordial and they're very respectful and polite with each other. And so you start you start looking for it there, maybe consciously or unconsciously. And then the closeness now and the affairs. And so you can see for Peter, that could be one hypothesis, that it wasn't there at home. And so he felt like the other person in the house. And the other thing that I might add is the wife now started influencing the 3 children they have, that their father doesn't love them. And so that has also become very heavy on Peter. And so at home, he feels unseen, he feels unheard, he feels misunderstood. Even when he tries to explain himself, he feels unimportant, the smallness. And so all these then contribute to a lack of emotional attunement. Contribute to a lack of emotional attunement and a lack of reciprocity. Like I said, because the wife might have emotional reasoning and is stuck to the idea that Peter is a narcissist. Peter could never do anything warm, could never do anything affectionate for her. So even when Peter is making an effort to do something for her, the wife is not able to say it. So there is a very significant lack of reciprocity in the marriage. And then when you look at the perceived burdensomeness, right? Here I would say it's mostly about self-loathing, hating yourself. And this can come as a result of feeling guilty for what you've done, or maybe for what you've not done. So this might be what we call inappropriate guilt that we often find in a depressive episode where everything is your fault, even when it's not your fault, and you're not able to think otherwise. Feeling ashamed for the way that you're doing things, feeling worthless, feeling hopeless, all these tend to contribute to perceived burdensomeness. Some of the things may overlap between burdensomeness and belongingness because they're not very far apart. And so when you look at the scale up there, you can see that when the levels of thwarted belongingness, TB, they tend to go together with perceived burdensomeness, right? So if the levels are high, then you see that the level of capability for suicide is also high. And in this one now, I want to ask you, what do you think is the risk? If we were to put out a risk 1 out of 10, 10 being the highest risk, what is Peter's risk of his capability for suicide based on these circumstances? 1 to 10, what will be his level? 10 being the highest level of capability for suicide. 6, 8, 7, 8, 9, 6, all above 5, 4, 6, 8, 8, 8, 7, 9, wow, 10, 7, 8, 10, 6, right, 7, yeah. Could you go back to Peter's story just to refresh the slide for Peter's story? Yeah. 6, 8, 8. Okay. Interesting evaluation. 6, okay. So just to refresh, this was Peter's story, yeah? And I highlighted the things in the slide for thwarted belongingness and perceived burdensomeness. Okay, so let's go back to the slide. I like the assessments. It'll be interesting to see the reasoning behind it. No, yeah, this one. So you can see majority had put Peter above 5. I think 1 or 2 had put him below 4. So then there is reason to be concerned about Peter, even though he doesn't seem to acknowledge that he is in danger. And the reason why he might not be acknowledging he's in danger is probably because for him, the thought of ending his, the thought of not being here, not necessarily ending his life, is not a dangerous thing. For him, it's one of the solutions. Because like I said, he's tried some things to help him out of the situation, right? He's tried to, buy the flowers that his wife says he doesn't buy. He's tried to, try to take his wife out. It hasn't worked. He's tried so many things in his own capacity, in his own way, and none of them have worked. And so now this passive desire to sleep and never wake up is actually an indication of some capability for suicide. Yeah. And in the study, when you look at it for the theory or the interpersonal theory of suicide, is that when we find ourselves enduring pain that is psychological and emotional for a long period of time, and our threshold to endure that pain goes up, the higher it goes, the closer it actually gets to the capability for suicide, because now you felt all the pain there is to feel. And you're starting to tolerate the idea that suicide might not be as painful, might not be as difficult as what I'm going through. And so suicide now becomes something that somebody thinks about as a solution, as a way out, as something that would end all of these problems. And so you can see that suicide doesn't, yes, we have impulsive suicide where somebody just in the heat of the moment thinks about it, but you can see in a lot of cases, up to 60% of suicide does not have an antecedent mental illness, but a person, because of the life challenges they're facing and they're frustrated because they're not getting a solution for it or an ease from it, then they start, tolerating the thought of suicide, right? Yes. So for Peter, I tend to agree that his level of capability for suicide would be at least 5, going upwards. And now the next slide. And so this is another paper by another researcher that was critiquing the use of this theory. It's very popular, I think, among clinicians and psychiatrists in using it to assess the risk of suicide or the threat of suicide. But in this paper, the things that he was criticizing is, one, that the burdensomeness is not always perceived. It's actually real. And I think I mentioned that. It is possible that you're living in an environment where the reality is you're not wanted there. And people are saying it in different ways very clearly to you that you're not wanted there. So that's not perception, that's reality. And you might see that this person might not have another way out. And it's really important to understand this, because I think the way that we look at suicide as psychiatrists, maybe me, I would give my own example, is in the past, because suicide is associated with depression and a lot of the figures come from a depressive episode, then the way that I would have a session with a patient would be to try and steer it in the direction of depression. And then the patient would feel very unheard, very dismissed, that the way that they think about suicide has to be about depression. And maybe it isn't. And so this theory allows us to expand that discussion, to start looking at how we can talk about suicide. Sorry, could you help me go back to the second slide, Dr. Marie? To see if we've tried to address some of the questions I was asking. The second one, just after the name. Yes, this one, yeah. Yes. So how can we talk about suicide in a way that invites conversation? And here you really want to understand, or at least create that space that is safe for the person to express their suicidal thoughts and to actually want to listen to them without wanting to convince them that they have something to live for, but to actually listen to them. And that does not promote suicidal. It is not going to make the person want to kill themselves more just by having that conversation. If anything, it allows them the space to think about what they think about suicide. As they're talking to you, they actually get to hear their own thoughts, and that might be helpful. Yeah. And so you want to be really curious when somebody has these suicidal desires to understand what may have led them to have these desires. And like we saw in this theory of the interpersonal therapy of suicide is thwarted belongingness. And so if they're coming to you and you think you're being helpful by telling them, oh, you've got a nice job, you've got all this income, you've got all these things, you've got kids, all this pride, they see that, they know that. Right. But there are so many challenges that are happening in between what they think they have and what they actually have, or what other people think they have and what they actually have, that it's very difficult for them to feel connected to them. Yeah. And so even if they're providing, there's no appreciation for that provision. Even if they're making an effort, there's no recognition for the effort they're putting to their family. And so they're feeling very disconnected from that. And you want to give them that space. And in that space, they might actually find an opportunity to renew, their hope in belongingness, because you might be giving it to them in that interaction. And so it doesn't have to be a big conversation, about mental illness or mental health. No. And in the studies that I've seen, they're actually encouraging the need to include, and this would be the second part, right? The need to include the different facets that the phenomenon of suicide affects, right? And so it's not just a psychiatrist that should deal with suicide. It can be a lawyer, it can be even a surgeon. Among doctors, it can be any doctor who does this, because like you can see, the factors that contribute to suicide are things that we struggle with on a day-to-day basis, things that you would be struggling with on a day-to-day basis. And so this person coming to you might actually also be giving you permission to talk about your own. And so I'm hoping that this has sort of broken down our perception of suicide, and we still take it with the seriousness, because again, the goal is to promote healing as the more viable outcome, and that would mean without reinforcing the suicide as the desired outcome. Because you see, the person who is contemplating suicide or who is actually planning for suicide, they're not looking at it as a threat. They're not looking at it as danger. They're looking at it as a desired outcome to the problems that they're struggling with, that are endless, that are intractable. And they're beginning to see themselves as expendable, like they can be replaced. And suicide becomes a sort of self-sacrificial act to the people they love. So it's actually a gesture of affection, or, a way of caring for the people they're leaving behind. And so you don't want to take the person out of that. You want to enable them. You want to create an enabling environment for them to be able to do that on their own, through that conversation, to enable your influence in creating that safe space, to make them rethink or to even hear their thoughts. Yeah, again, and maybe that might be enough to tell a person, do I really want to die by suicide? I mean, that might actually stimulate maybe an alternative coping strategy, something they haven't tried, but you don't want to be the one telling them, oh, try this, because usually they have tried. So you really want to give them a space where they can tell you what they've tried without you interrupting them before they get there. And yes, so I really hope today in the discussion, we broke it down. Please, let's go back to that slide for the thwarted belongingness, and this one, just before. This one you can read to look at the criticism about the previous slide. This one now. I'd like to engage you again. And then the last slide is the last one. So in the last 1 month, let's say, how many have struggled with any of this? You struggled with feeling seen, feeling unheard, and it could be in the context of workplace or away from the workplace, at home or with neighbors, with friends. How many have experienced? Just type the one that you have in the last 1 month. You felt unseen, you felt unheard, you felt misunderstood, you felt unwanted, unimportant, any of them. You felt guilty, you felt ashamed. Oh, they've got they've got 2 numbers. In the last 1 month, misunderstood. These are things we experience, yeah? We struggle with on a day-to-day. Ashamed. 6 is feeling unappreciated, unimportant, hopeless, small. So these are conversations that you can relate with, which means then a conversation about suicide should not be very dreadful, or should not be very difficult to engage in. Unheard, misunderstood, guilty, unimportant, misunderstood, unwanted, ashamed, hopeless. So we feel these things, yeah? But maybe not every single day. Because if you look at the previous slide, sorry, let me bother you again. The thing that makes these feelings hopeless is they're not ending. They're intractable. So they're there all the time. And they're there all the time, maybe because they are, really they are, or because your perception of them never ends. And so maybe your partner may have misunderstood you once, but then you've taken that one interaction that is real and you've planted it in your mind, and now you're constantly looking at it. When you see your partner, you see that interaction. And so whatever your partner does, and this now might factor in the emotional reasoning, where you've stuck to that belief one time, but now you repeat it in your mind and the interactions are different. So that makes it perceived, right? And so you want to assess yourself that way to see if your partner is actually making you feel unwanted, or your colleague is making you feel unheard, or maybe they did it once, but the repetition is in your mind. So whenever you meet them, whenever you interact them, that interaction comes in and you block out any real interaction with this person. And so it looks like it's unending, but really it's just in your mind. And I can share this with you from my own clinical experience, is that this happens a lot more, that we replay things that happened in the past once or twice in our mind so many times that it feels like we're stuck in them, such that when we come to examine reality, let's look at what they did. Before we interpret what they did, let's look at what they did. And you find that there's a stark difference. There's a huge distance between what this person has done and what you thought they did once, that you've kept repeating in your mind that they're still doing, right? And this realization is usually a very good breakthrough, because then the person comes back to reality, steps back into reality, and is able now to deal with what reality is giving them, not what they've created in their mind about reality. Yes. And thank you very much for the responses. I think the last slide is me telling you what I've been saying in the last hour and 20 minutes. And thank you very much for being patient. I know there's a book that was written that says, don't sweat the small stuff. It's all just small stuff. I think I'm going to say the opposite of that, because it is the small stuff that actually gets to us, that actually gets us to think about suicide, that actually gets us to start desiring suicide. Because on Peter's story, it was small things that started piling on each other over time, such that now when you look at it, it looks like this big mountain, but it's made of small things that you thought, oh, let me let it go. Let me not make a big deal out of it. Let me not overreact. And every time you say, let me not overreact, let me let it go, it just piled on there, and then the next one and the next one. And now when you look at it after 2 months, after 2 years, it's a whole mountain and you don't know where to begin. So mine is sweat the small stuff. And here, small stuff would be, yes, there's some stuff that you need to let go, but there's some small stuff that you really need to address there and then and not carry it with you. Yeah. And so that would be my message today. Sweat the small stuff, because most of life is just small stuff. Thank you very much for listening.
Thank you so much, Dr. Nema, for that wonderful presentation. We'll take about 5 minutes for any questions that may be there. So maybe if anyone has any questions, they can type them in the Q&A section, which I see we have a few. And if you'd like to ask it live, you can raise your hand and we'll upgrade you. So most of the questions were actually comments on the questions you were asking, Dr. Nema.
Yeah, yes,
So
I see them.
yes. So probably if there's any question, we could do that. But if not, maybe do you have, besides your parting shot of sweating the small stuff, do you have any key lesson to summarize what we've discussed for the past 1 hour 20 minutes?
No, I think if I say more, it won't be valuable. So let me stick with that. Sweat the small stuff. Yeah.
Oh, we have a question from Nancy
Mm.
Jepchum. She's asking, could you explain mind filtering again?
So mind filtering is you get into a situation, and a situation would have positives and negatives. sometimes simultaneously happening at the same time, but your mind filters out the positive. And so you don't see how maybe you felt excited when you went to this social event. You don't see how you felt thrilled when somebody came up to you and said hi, but you see how you awkwardly, responded to the hi, or how you over-explained yourself, or how how you dressed didn't match the mood of that event, right? And so you miss out on even how the food was nice. Maybe the cake was not as nice, but the main course was. And so you filter out all the positive, and your mind just seems to look at all the negatives that happens. That's filtering. And it can be very conscious or unconscious. Oh, thank you very
Right.
much.
Fantastic. I see there's no other question, but people are giving their compliments over the presentation. I hope you're able to see them on the comment section, the chat section.
Yes, thank you very much.
Yes. So from the Kenya Medical Association Physician Wellbeing Committee, we'd like to thank all 260 at one point. Now we are 230. So I'd like to thank all of you for making time to attend this pivotal webinar that was commemorating the World Suicide Prevention Day. This is going to be a monthly series. So next Tuesday, we're going to have another webinar talk. And this webinar, if you missed out the beginning, will be shared on our YouTube channel, so for you to also have a recap of it. So from our end, we'd like to say thank you very much and enjoy your evening ahead, and see you in the next webinar.
Thank you very much. Thank you for the nice comments. I really appreciate it. Thank you, and have a good night.